So now the main thing I want you to take away from this slide or this video is each time you look at an ECG, remember the acronym or remember the mnemonic RRPWQST. RRPWQST. So I have it on the screen now. So the R stands for rate and the second R stands for rhythm. P stands for the P wave, W for the W width of the QRS mainly, and the Q wave is a pathological wave, and to check whether there are any deep pathological Q waves, and S for the ST segment, and T for the T wave. Now, the rate we understand how to calculate from just the RR interval, 300, 150, and then 100, 75, 60, and 50. Now the rhythm. A regular rhythm usually means that there is the same number of squares between each QRS complex. So on the screen now, where the mouse is pointing to, you can see here the number of squares between each QRS complex is not regular. Here is different, here is the same, but here is different again, different, same, different. So here clearly there is not a regular rhythm. So this is the normal regular heart rhythm, and means that the electrical impulse starts in the sinoatrial node. So from the rhythm, you can tell from just looking at the ECG, from seeing the RR interval constantly, you can check whether there is a normal regular rhythm. After you check the normal regular rhythm, the next thing you want to look for is P wave. So it's RRP. Remember, it's RRP. So it's P wave and then W. So the P wave is there, one P wave before every QRS complex. If there is more than one P wave before each QRS complex, then there is some sort of conduction to the some sort of blocked conduction, or there's an abnormal conduction to the ventricles. This is called a heart block. For example, on the screen you can see that there is multiple P waves prior to each QRS complex. So you know that the atria is functioning, the SA node is firing, and the atria is depolarizing and contracting, but there is no presence of QRS complex, i.e. so there's some sort of block. So the firing electrical activity is not going down from the AV node into the bundle of his and into the ventricle, so there is some sort of heart block. Now let's talk about the width. Before we talk about the width, we need to know whether there is sinus rhythm. Sinus rhythm basically means that there is always a P wave preceding a QRS complex. A normal ECG always starts with a sinus rhythm. Here is a sinus rhythm, but it's not sinus non-regular rhythm, since there is a P wave and it's not regular. And here in this case, there is more than one P wave, indicating that there's some sort of heart block. Now, the width is very important. The width of the QRS, from earlier, you should know that there is meant to be 3 small square boxes, or 120 milliseconds, less than or equal to 120 milliseconds. Now, if there's greater or more than 3 small squares, that means the spread of electrical activation through the ventricles must be slow. This could be because of abnormal conduction or something. Now, the next is, so we've gone through RR, P, W, QST. Now Q stands for pathological Q waves. If the QRS complex starts with a deep downward deflection, this may be due to an old myocardial infarction. So instead of a regular R wave or a QRS complex, if it's just a big negative Q wave, a pathological Q wave first, and there is no R or S wave, then this could be due to someone suffering from a old myocardial infarction. The ST segment is the next in line, and you can check this, and the ST segment usually would reveal if there is an elevation or a depression. Elevation is usually due to myocardial infarction, and a depression due to some sort of ischemia. Both come under STEMI and non-STEMI, which we'll discuss further later on throughout the course. Now a T wave is the final one that you should look for. If there is normally a T wave is upside down in VR and in V1, but in rest of the leads, so everything else apart from VR and V1, the T wave is usually up or positively deflected. If they are negatively deflected, apart from these two leads, VR and V1, that means there is some sort of cause for ischemia or ventricular hypertrophy.